With all your permission now, we are beginning with the session for today. Good
Yes.
afternoon, everyone. This is Batu from ITCP, moderating for today's session, and I'd like to welcome everyone more heartily at our platform for the better exchange of knowledge that is going to be shared by our renowned stalwart who is present here with us today. Well, ma'am needs no introduction at our platform, but it's great pleasure and honor to introduce her. She is none other than the very renowned gynecologist, Dr. Anita Kant, ma'am. Ma'am is MD in Obstetrics and Gynecology, Fellow of Indian College of Obstetrics and Gynecology, Chairman at OBG Services at Asian Institute of Medical Sciences, Faridabad. With ma'am's wonderful insights, we are going to talk about the topic for today, which is contraception for cancer survivors. And before moving on to today's discussion, let us have a brief look on what the topic says. Embarking on the journey of survivorship after cancer treatment brings a multitude of considerations, including fertility and family planning. In this enlightening webinar, as we explore the complex intersection of contraception and fertility preservation for cancer survivors, our expert will be addressing the fertility considerations post-cancer treatment, understanding the impact of cancer therapies on reproductive health and fertility, including potential risks and challenges. So now, without any further delay, I would like to welcome ma'am at our forum and would like to hand over the session to him for her precious talk to begin. Ma'am, over to you.
Thank you. Good afternoon, everyone. Today, I'll be talking about contraception in cancer survivors. So as we start the session, let me tell you that most of the things I will be talking about, you would all be knowing. It's just that we need to spread the awareness and knowledge to our patients and also to our colleagues so that, the more and more women can make use of this particular contraceptive advices. So contraception, as you know, is the key for prevention where pregnancy is not intended. Cancer survivors have unique family planning needs. 80% of women diagnosed with cancer before 50 years of age have more than 5 years survival. But so many of them feel that they have unmet reproductive health needs. They also have limited awareness about what contraception to use, maybe because this is not a part of the post-cancer life needs told to them. While chemotherapy and radiation will reduce fertility and may cause even premature ovarian failure, but many of the survivors remain fertile, and that is their problem. And many of them will also be wanting to have babies, wanting to remain fertile. So where do we lead them from there onwards? As a result of next please. As a result of advances in diagnosis and treatment, young women and even adolescents are more likely to survive cancer. Among childhood cancer survivors, treatment is thought to reduce the fertility but only by 10 to 15%, depending on the type of treatment received. At present, there are limited guidelines for clinicians in achieving the unmet needs of contraception in this group of women. Cancer treatment is thought to reduce the fertility, and depending on the treatment received, it varies from 10 to 25% of the females treated. Data from Norway suggests that 10 years following a cancer diagnosis, they compared women who had never had a baby but were not having cancer and women who were treated for cancer. And they found that the women who were treated for cancer were half as likely to become pregnant compared to the other group. So you see, it is not as though the cancer treatment is not going to allow them to become pregnant, only it is reduced by about 50%. So reproductive age groups fertile women undergoing cancer treatment are generally advised to avoid pregnancy due to the concerns of teratogenicity, which is caused by chemotherapy or radiation. And naturally, if they conceive despite that, they are at a very high risk of pregnancy complications. Many women themselves will choose to prevent pregnancy once they read more and more about it online and learn from other people, their compatriots or the doctors. So prognosis, risk of recurrence, return of fertility, and need to be counseled to every patient before going ahead with pregnancy or going ahead with contraception till they decide to become pregnant. Some cancer treatments, like pelvic, ovarian, or CNS irradiation, or non-alkylating chemotherapy increase the risk of pregnancy loss and low birth weight babies. Contraception may be desired to allow women to ensure their pregnancy to coincide with a period where their health is the best and they can afford to have a baby. At times, the goals of cancer care may conflict with the patient's reproductive goals, which can be minimized after counseling and prevention, especially in a very young girl who's uh, planning pregnancy and she suddenly comes to know she has a cancer, maybe of the breast or of the ovary. So we need to sit with her and tell her what all options she has so that her fertility also gets conserved, her ovaries are not unduly damaged, and she can plan a pregnancy later on. So first of all, how is fertility assessed in a cancer survivor? Does this patient need contraception? If she doesn't, we don't need to add extra medicines to that already harassed lady. So how do we know? Absence of menstruation does not necessarily indicate lack of ovarian function, that is ovulation. Even menstrual activity, which may not be regular or may be irregular, is not a reliable index of ovarian function. So certain hormonal tests and antral follicular count, etc., have been used to estimate the ovarian reserve. Next, please. Next. First of all, fertility needs to be assessed in cancer survivors and their contraception needs are met afterwards. Ability to conceive needs to be judged and usual signs, like I said, are not reliable. That is, absence of menses does not mean that she may not ovulate at any time. FSH, inhibin A, inhibin B, AMH, ultrasound to assess the antral follicular count, and ovarian volume have been used for assessment of fertility. Currently, AMH is considered to be the best predictor of all of these of a woman's future fertility. Acceptability of a patient depends on the type of contraceptive method advised to her, because she has to know associated bleeding pattern, initiation of the contraceptive method, when to start, effectiveness of the contraceptive method, desire for future pregnancy, and any non-contraceptive benefit of that particular method. So contraceptive options would be, as per WHO, tiers 1 and 2 include male and female sterilization, intrauterine devices, pills, they may be estrogen and progesterone or progesterone only, and other hormonal methods. Tiers 3 and 4 include condom, periodic abstinence, withdrawal method, cervical cap, etc. Tier 3 and 4 are not very reliable, so usually not recommended, and they're not usually well accepted by the patient also, because there is a high failure rate of about 15 to 32% per year. Primary cancer type also influences recommendations regarding the contraception, especially for breast cancer or other hormonally mediated cancers. The number of women in reproductive age group who currently have or are recovered from breast cancer is increasing day by day. For women with breast cancer, exogenous estrogens and progesterones are not recommended due to concerns that they may increase risk of cancer recurrence. Actually, a consultation with their oncologist has to be done, because estrogen and progesterone receptor status affects the tumor growth and also will tell the prognosis in case such a medication is given to the woman. Data on impact of postmenopausal hormone replacement and extent to which use of estrogen containing contraceptive have been used will increase recurrence rate or not is lacking evidence. So the risk remains theoretically more than practically, and we have to work more on it to be able to give a clear-cut statement to the patient so that she can use or she strictly cannot use hormonal contraceptives. Similarly, the role of progestins in breast cancer in both pre and postmenopausal women remains understudied. Oral medroxyprogesterone acetate has been shown to have some evidence as a chemotherapeutic agent, and progesterone-only pills have not been associated with an increased risk of breast cancer, but the studies are far and in between. The copper T380A is the most effective hormone-free reversible contraceptive for the breast cancer survivors if they agree to use it. Breast cancer, next please. Breast cancer survivors are advised to avoid pregnancy for at least 3 years following the cancer treatment due to concerns that pregnancy-related hormonal changes may increase the risk of recurrence. So, she's caught in a place where she cannot get pregnant and also where she is not advised to use very many contraceptive methods. So we have to help her out. And property till date is the best we can offer women with breast cancer. For women being treated with tamoxifen, which can cause endometrial proliferation and even endometrial cancer, endometrial polyps, the LNG-IUS example, Marina, may be optimal for both contraception and also its endometrial effects. And if there is an added endometriosis, that also will be taken care to some extent, as it decreases both endometrial proliferation and the need for investigation in case any vaginal bleeding happens. Only one study out of several noted that women who were using Mirena LNG-IUS at the time of diagnosis of breast cancer and who continued to use it had significantly more likelihood of recurrence of breast cancer. So more research is required to determine its long-term safety. Now we will come to other issues. So how does venous thromboembolism affect contraceptive selection? Both cancer and estrogen are independent risk factors for VTE. Cancer patients with venous thromboembolism have twice the mortality when compared to those who do not have VTE and have never had this complication. So WHO and CDC recommend that women with active cancer or those who have been treated for cancer in the last 6 months should avoid combined oral contraceptive pills, and thus this is meant to avoid intake of estrogen in them. Progesterone only pills increase the risk of VTE relatively less when compared to the estrogen containing pills. On the other hand, DMPA, which is an injectable contraceptive of progesterone, has a very high risk for VTE. Next, please. Some common complications of treatment and contraceptive selection have to be noted, because treatment for cancer will lead to these problems, and accordingly we have to select which contraceptive to give them. First being anemia. Anemia affects the quality of life. For women with anemia and cancer, especially in lung cancers and gynecological cancers, efforts to minimize menstrual blood loss with progesterone only pill or LNG-IUS may be helpful. Copper T, on the other hand, may increase the blood loss and worsen the anemia. An implant can lead to unpredictable bleeding profile through the course of its use, so it's best avoided. Radiation to chest has been given to many people, many women for various cancers. So women who have received radiation to chest have an increased risk of developing breast cancer and thus should avoid estrogen or progesterone because it can add on to the risk. Copper T is to be considered as the first choice amongst them. LNG-IUS, which produces the lower serum hormone, is the second choice. Modern OC pills are said to have very low doses of estrogen and progesterone. So some studies have quoted that they are not associated with risk of developing breast cancer. Next, please. Osteoporosis is again a common complication of chemotherapy. For women with pre-existing bone loss, use of DMPA should be considered with caution, though its effect on bone mineral density have been found to be reversible. Implants are also known to decrease the radial and ulnar bone mineral density, but association with increased risk of fracture is not known. LNG-IUS does not adversely affect bone mineral density, so can be used preferably. Estrogen-containing contraceptives may be advantageous for women because estrogen helps building bones. So osteopenic women may benefit for it, but studies show a mixed result. Next, please. Immunosuppression is a very common problem with those who have had cancer treatment. There is limited data on IUD used by women who are immunosuppressed due to cancer treatment. WHO and CDC state that IUD is safe for use. Infection risk with IUDs in immunocompromised women is very rare. Next, please. So coming to the next, is emergency contraception safe for women with cancer? There are no studies available in literature. CDC postulates that emergency contraceptive pills have fewer clinical repercussions than combined OC pills or progesterone-only pills, as the duration of use is shorter and the hormone given is much lesser than the whole month cycle hormone. However, once given the freedom to use it, women may tend to use it frequently, and frequent repeated use would surely affect women who have been advised to avoid hormonal contraceptive methods. Copper T is a safe and effective emergency contraceptive. Ulipristal acetate can also be offered to them. On the other hand, does contraceptive use affect a woman's risk of developing cancer? OC pill use has been shown to increase the risk of breast cancer for up to 5 to 10 years after use also. But this was for the large amount of estrogen contained in the olden time oral pills. Long-term follow-up has shown to increase in mortality, has shown no increase in mortality from breast cancer in the former users of combined oral contraceptive pills. And the reason given for this is that those who use combined oral contraceptive pills somehow are more health conscious, and they are in the counseling taught to look for breast lumps, and they turn up early with small lumps and get treated early, so there is no increase in mortality. Use of injectable contraceptives and implants of progestin only have not been associated with an increase in risk of breast cancer. Use of hormonal contraceptives actually decreases the risk of endometrial and ovarian cancer. Copper T or LNG IUS use appears to reduce the risk of endometrial cancer. Their effect on ovarian cancer has been found to be inconsistent. For women who are BRCA1 or BRCA2 carriers, doses of progesterone that can suppress ovulation are preferable to prevent ovarian cancer when compared to barrier or intrauterine method of contraception. Next, please. So what is the recommended contraceptive use in cancer survivors? For women who have been cancer-free for at least 6 months and have no history of hormonally mediated cancers, chest wall irradiation, anemia, osteoporosis, or VTE, use of any method of contraception can be recommended. In women with cervical cancer, while they await their treatment, best suggestion for contraception would be a POP pill. Next, please. So to conclude, the recommendations are: combined oral contraceptive pills should be avoided by women with active cancer who have been treated for cancer in last 6 months due to increased risk of VTE. For women with a history of breast cancer, copper T is highly effective. A hormone-free method is recommended. For women with anemia, LNG IUS may be used to minimize the blood loss and so that the anemia does not worsen. Next, please. For women with breast cancer treated with tamoxifen, LNG IUD is highly effective contraceptive, which will additionally reduce the endometrial changes secondary to tamoxifen without increasing the risk of breast cancer recurrence. For women with history of chest irradiation, systemic estrogen and progesterone should be avoided. Women with osteoporosis or osteopenia should avoid injectable progesterone-only contraceptives. Estrogen-containing contraceptives may be beneficial for women with osteoporosis or osteopenia. Next, please. Women with immunosuppression may safely use intrauterine contraceptives. Emergency contraceptive pills may be used by women at risk of breast cancer or breast cancer recurrence who decline emergency placement of a copper T. Thanks for patient listening. I will wait for any questions from the audience.
Thank you so much, ma'am. Thank you for your overwhelming talk that you have shared on our platform on such an important topic and for making our viewers understand about the topic in such a better manner. Thank you so much for that. We have received few questions from the participants. So with all your due permission, I would like to put across those
Yes,
questions to you. So the first question
definitely.
is related to the emerging trends. So what are some emerging trends or research developments in the field of contraception for cancer survivors that practitioners should be aware of?
See, I have taken all those sources which are as per the guidelines given in the, I have quoted it also in the sources. This is 20 November 23 guidelines. So these guidelines I have quoted, and according to that only I have made the recommendations. There are a lot of lacuna in the research and its actual application, because somehow it feels that not very many people are interested in telling the patients about what is happening to them after the cancer is over and after they are resuming their regular lives. So naturally, more and more studies are required before definitive treatment protocols can be given. Okay, you can give estrogen up to this to breast cancer survivors. You can give progesterone only pills to cancer survivors. So those all are lacking. Whatever I could get out of that statement of theirs, it's a long statement, and I have written that in this method.
Thank you so much, ma'am. Thank you for answering that question. We will move to the next question, and the next question is related to the role of long-acting reversible contraception in cancer survivors, considering both safety and effectiveness.
See, LNG IUD is a LRC only, and that is really preferable, especially in breast cancer also, and where endometrium also gets protected from tamoxifen. Other cancers also, this can be used very safely because a very small amount of progesterone is secreted into the uterus itself, and into the bloodstream. Very little progesterone is going, so naturally the side effects are going to be less. But depending if the woman has any such problems like VTE, or she has any anemia, or she has osteoporosis, then definitely we cannot give those injectable progesterone only hormone implants or DMPA injections, because they have their own side effects which will add on to these problems that she is already facing.
Thank you so much, ma'am. Thank you for answering that question. Next question is related to the potential interaction. So what are the potential interactions between hormonal contraceptives and cancer treatments or cancer recurrence risk?
See, cancer treatment, contraception is only given after cancer treatment has stopped, and at least a 6 month gap has happened. Only then we go for any of these type one or two type of contraceptives that we advise to the patient. If they are hormonally dependent cancers they have suffered from, definitely estrogen and progesterone are not to be given. Then the best would be that they go for copper T, or if at all, then LNG, IUS after proper counseling, and ulipistol can be used as a emergency contraceptive for them.
Thank you so much, ma'am. Thank you for answering that question. Moving to the next question, and the next question is related to the strategies. So what strategies can be employed to address potential barriers to contraceptive use in cancer survivors, such as financial concerns or misconceptions about safety?
Even before a cancer treatment is started, especially in the young people, one should sit down with them. And if they have not had any children, or they are wanting more children, then as we know, ovary has to be protected. And if at all it is an ovarian cancer or it's a breast cancer, sometimes they go for zygote preservation and freezing their ovums. So all these strategies have to be explained to them. And in those who have already had children, they have completed their families, they've completed their treatment, they can also go for permanent sterilization method. The male partner can also go for that. And after that only they should be told, well, yes, you are not, even if you may be having amenorrhea, does not mean you're immune to getting pregnant. You can get pregnant, because these kind of failures do happen all the time. And depending on that, they have to be told that this is the menu card available. These are the options available for you. And then let them sit down and take a positive reaction and decide which one they want to go for. Like I was again and again saying, many breast cancer survivors do not want to have a copper teapot. Something somewhere goes in their mind that they don't want to have something put inside their body. Maybe it was a breast cancer and tomorrow it may affect my uterus. That kind of barriers we do find amongst patients, especially in India.
Thank you so much, ma'am. Thank you for answering that question. The last question before we conclude the session, and the question is related to the importance of interdisciplinary collaboration between oncologists and reproductive health specialists in providing comprehensive care for cancer survivors regarding contraception.
I would go forward to this. I would say not only the oncologist and the reproductive health provider, we sometimes, if these women have any additional problems like, let's say, osteoporosis, an orthopedician may be involved. If they have any medical problems associated like diabetes or hypertension, it is very well known that women, even young girls, also suffer from these problems. Then a physician may also be involved, and a multidisciplinary approach is definitely required. Even we have patients coming to us who will say, hey, my mother had a cancer of somewhere of the genitals, and please remove my uterus. So we have to sit down with them and find out why. Did she have ovarian cancer? Did she have uterine cancer? Cervical cancer? You tell us the kind of cancer she had, and if you can take out her papers, then we will like to look at what was positive. Was it a genetic kind of a cancer which you can also get that, and only then it's worth it that you undergo a major surgery without any indication. So these are the things that we fall into these traps again and again, because patients don't know कोई भी cancer हुआ था in the stomach they related to, वो तो जी uterus से related था. So these things, and mother is no more, she does, and they don't have any papers. So these kind of problems happen all the time.
Thank you so much, ma'am. Thank you for answering all of our questions and for making our viewers understand and solving their query out there. Thank you so much for reaching out to us with this. And I would like to thank all of our viewers for their ardent participation that they have shown by staying tuned with us throughout the session and putting across such interesting questions to us. So thank you to all of them. And ma'am, with this and with all your last comment, we
Thank
would
you.
like to conclude the session here for today.
Thank you for patient listening. I would like to say that it's after cancer, definitely women need care, and we have to provide all of this to them whenever a patient comes to us. And more than that, we need to prevent cancers by telling women how to breast self-examine, go for gynae checkups, go for pap smear, go for the HPV vaccines, so that they prevent cancer from happening to them.
Thank you so much, ma'am. Thank you. With this, with your wonderful note, we are concluding the session here.